Hello, everyone. Thank you so much for joining us tonight for our patient webinar on Dry Eye Solutions 2025 Modern Treatments and to Restore Comfort and Vision. My name is Leanna. I'm the Digital Marketing Coordinator at Harvard Eye Associates, and I'm pleased to introduce our speaker for tonight, Dr. Ashraf F. Ahmad, our board certified ophthalmologist who specializes in cornea, cataract, and laser vision correction procedures. Dr. Ahmad cares for patients with a wide range of eye conditions from cataract and corneal disease to vision correction options like LASIK, PRK, and EVO ICL. He's known for taking the time to explain treatment options clearly and helping patients feel confident and informed every step of the way. Dr. Ahmad completed an accelerated 6-year BSMD program, graduating with honors from Kent State University and earned his medical degree from Northeast Ohio Medical University. He then trained at some of the nation's top institutions, including the Cleveland Clinic and Case Western Reserve University, where he served as chief resident and was most recognized as the most exemplary resident. He went on to complete advanced fellowship training in cornea and refractive surgery at University of California, Irvine, where he developed special expertise in advanced cataract surgery, corneal transplantation, and laser vision correction. Dr. Ahmad is now an active member of the American Academy of Ophthalmology and the Orange County Society of Ophthalmology. He's fluent in Arabic and conversational in Spanish, which helps him connect with and care for a diverse group of patients. And we're very happy to have him with us tonight. Without further ado, please join me in welcoming Dr. Ashraf Ahmad.
Thank you so much, Leanna, for that introduction. And thank you to everyone who's taking the time from their evening to join us for an informative session. Briefly, I do a lot of complex surgery, but then I also have a special interest in dry eye, particularly refractory dry eye. So we see hundreds of patients every month who are coming in with dry eye symptoms, who have been going on without relief and are sort of looking for that next step that's going to provide that comfort. And we have a lot of ground to cover today. I'm going to basically give you guys an overview of what the current treatment options look like in the dry eye sphere. And these are in continual evolution. So every year there's newer and newer medications, newer and newer procedures that are available. But we are always at the forefront and in basically bringing in and optimizing these treatment options for you. And so we'll go through an overview of what we're going to be discussing today. We'll talk about why dry eye happens, and what are the risk factors that are commonly predisposing to it. We'll talk about some of the common symptoms that patients are experiencing that bring them in. A lot of them you may not necessarily associate with dry eye, but there are some that are very, very common. And then we'll talk about the first line treatment options like over-the-counter artificial tears and over-the-counter medications. Then we'll jump into some of the prescription medications and steroids. And then we'll kind of pivot into the procedure-based options like punctal plugs, amniotic membrane, and then we'll pivot into the biologics, which would include serum or autologous or blood tears, scleral lenses, and some of the in-office procedures that we have. And then we'll have a short Q&A session at the end to answer any questions that come up. So real quick here, what is dry eye? And so I always like to think of dry eye as a multifactorial disease. So there's so many reasons that contribute to it. And essentially at the core of it, it can be distilled down into two things. One is going to be inflammation, and two is evaporation. So anytime you have inflammation on the eye, that leads to desiccative stress, and that desiccation leads to evaporation. Evaporation of your tear film can lead to inherently inflammation as well. So there's sort of this connection and interplay between inflammation and evaporation that leads to dry eye. And a lot of times patients are experiencing dry eye, but they don't necessarily understand why they're experiencing it or what it necessarily feels like. And so dry eye is very, very complex, but there are some basics that we'll go over here in just a moment. Now, why does dry eye happen? This is probably the most common question that I get every single day. And it's really hard to give a straightforward answer to it because there are so many factors that are associated with it. So we'll go over some of the most common risk factors, but then these are not all encompassing or all inclusive. There are so many beyond these, but we'll touch on the highlight ones and the ones that are the most common. So starting with excessive screen time. Each and every one of us is on digital devices every single day for extended periods of time. And based off of the age category, you're looking at anywhere between 9 to 12 hours of screen use. That leads to a reduction in your blink rate. And so patients are not blinking as much whenever you're super focused on something. And that leads to evaporation. Evaporation leads to inflammation, kind of that cycle that we had talked about. So that's one of the most common risk factors. Secondly, your environment. So, especially here in Southern California, it's a drier climate. People are using ACs, they're using fans. All of that can lead to dryness and dry eye. Then we have hormonal and age-related changes. So we know that as we age, we lose meibomian gland function, we develop some inflammation that leads to dry eye, and then hormonal changes, usually as they're related to estrogen and things of that sort. So females are more likely to have dry eye than males are. Medications, so this is usually an overlooked category. So if you're taking or oral anti-allergy medications, oral antihistamines, you're on antidepressants or anti-anxiety medications, those all have a side effect of dry eye. So I always like to look at your medical record, looking at your medications to see if there are any medications there that can lead to it. Even topical medications. So for those of you that have glaucoma and you're taking topical drops, those drops often have preservatives in them, and that can lead to dry eye as well. And then contact lens wear is a very, very common category. So a lot of our patients are contact lens wearers. Chronic wear and chronic use of contact lens can lead to dry eye. I will also say that any ocular surgery, whether it's LASIK, whether it's cataract surgery, retinal surgery, glaucoma surgery, any type of ocular surgery can also lead to dry eye. So that all kind of plays into it as well. And then we also look at your past medical history. So if you have a history of diabetes, for example, or any autoimmune condition like lupus, rheumatoid arthritis, Sjogren's syndrome, that can all be a risk factor for the development of dry eye as well. And like I said, this is not an all-encompassing list, but these are some of the more common risk factors that we see. Now, as far as symptoms go, what are patients experiencing that's bringing them to see us in the first place? So, some of the more common symptoms are going to be burning and stinging, redness, watering. I like to focus on watering because it's a little bit counterintuitive. So, when patients experience watering, they don't necessarily think the first thing is dry eye, but actually, watering is probably one of the more common signs that we see of dry eye. And why that develops is essentially your body or your eyes are trying to keep up with the dryness, and so they're trying to produce more and more tears. But those tears are lower quality tears, so they're evaporating very quickly. And then you're sort of stuck in this cycle or in this loop where your eye is trying to compensate for the dryness, but the tears aren't good quality. So that's first and foremost there. Fluctuation in vision is dry eye until proven otherwise. So that's probably the most common thing that we see. If you have like fluctuation, whether it's minute to minute, hour to hour, most likely that's actually dry eye. Grittiness, foreign body sensation, light sensitivity, redness, all of that is dry eye until proven otherwise as well. Now, there are different types of dry eye. And like we talked about, there's the inflammation and then there's evaporation. Evaporation makes up the more prominent component of dry eye, but then inflammation or aqueous deficiency, where you don't have enough tear production, that also makes up a subset of dry eye patients. The majority of patients have a mixed variant where you have some inflammation, you have some evaporation, and that's what's leading to your dry eye. So the majority of patients will fall into that third category where we need to address both components to really find that symptomatic improvement. Now, when should you see a doctor? Why artificial tears alone or over-the-counter medications are not enough? So artificial tears, it's going to be a foundational treatment for most of our dry eye patients, but it's not going to be enough to address the underlying issue. Artificial tears, they provide relief. They don't fix necessarily the inflammation. They don't necessarily heal the surface. They provide a nice barrier function, but they're not really addressing the main components of dry eye. They're more just symptomatic relief, a band-aid, if you will, but they are an important and an integral component to your dry eye treatment. They don't address the oil gland issue. They don't help regenerate the nerve if that's an issue that you're dealing with. So they don't really get to the heart of the problem of dry eye. But like I said, they are important to start out with because for a lot of mild dry eye patients, they're enough to improve your symptoms and enough to provide relief where we don't necessarily need to escalate into the prescription pathway. Now, with preservative-free artificial tears, we do recommend that if you are going to use over-the-counter tears, that you reach for the preservative-free ones. And they will say PF on the box or preservative-free will be spelled out. The reason why that is some of the artificial tears that are out there may have preservatives in them. And if you use chronic use of artificial tears that have preservative in them, that preservative can actually build up in the cornea and cause toxicity, which can then actually lead to another cycle of dry eye. So it's best if you are struggling with dry eye to only buy the preservative-free ones. And the way that you'll know it's preservative-free is they come in individual vials. So they're the kind that peel pack. You use the individual vial for the day. They are recapable, so you can use it throughout the day. And then they recommend that you throw them out at the end of the day just to minimize any risk of infection. There are a couple of companies that are actually producing a preservative-free bottle. So Systane, for example, has a preservative-free bottle. Ivisia is one of the newer drops that's preservative-free and comes in a bottle form. So for those of you who don't like the individual vials or have trouble with dexterity and actually using the individual vials, it might be easier to look into those preservative-free bottles instead. Next up, we have warm compresses. So this again is part of our foundational treatments. For warm compresses, the reason why we do them is in your eyelids, you have oil glands that run vertically in the upper and in the lower lid, and the opening is right at the eyelid margin. And you need the oil component to your tear film for those tears to last longer. Without the oil component, your tears don't last long and they evaporate very quickly. So if you have blocked oil glands, and a lot of us do, the majority of my patients who come in with dry eye have some form of meibomian gland dysfunction, meaning the oil glands are blocked. We need a way to basically soften them so they express on their own so that your tears are more effective and they effectively last a little bit longer. There's a couple of ways to do the warm compresses. You can do a microwavable mask, which you can get at any pharmacy. You can get it on Amazon. They'll ship it out to your home. And you essentially just put it in the microwave for 10 seconds, usually 10 to 15 seconds, depending on your microwave type. And then you use it for 5 minutes. The reason we like the mask as opposed to like a washcloth is because the mask itself will retain the heat a lot better than a washcloth would. So you don't have to necessarily keep going back and forth to reheat it. There are also electrical warm compresses that you can kind of plug into an outlet. They charge and they can heat up. I've seen some patients with wands that heat up as well. Find something that works for you that you can actually maintain. And I usually say you do it once or twice a day for 5 minutes at a time. It's not something that you need to sit there extensively, like 30 minutes, 40 minutes, 50 minutes. That's too much time out of your day doing something like that. So keep it simple, just once or twice a day, 5 minutes at a time. Now, when should you really think about escalating therapy? When is over-the-counter tears not enough? And when should you see a provider? Essentially, if you're doing over-the-counter medications, you're doing the warm compresses, but you're still having a lot of symptoms, you're having a lot of fluctuation in your vision, you're having redness, irritation, ongoing changes that are not improving or responding to your usual therapies. That's the next time that you really should come in and see an eye care provider. And so that kind of leads us into what do we offer when you come see us? Typically, by the time patients come and make an appointment with me, they've already exhausted some of the over-the-counter options. They've already been doing the warm compresses, and they're looking for something that's going to provide more relief. And that's where the prescription drops definitely come in. So we'll start with cyclosporin. Cyclosporin has been around for decades. It's one of the earliest medications that's been in eye care specifically for inflammation and the improvement in dry eye. It comes in various formulations. So some of the branded medications that you'll see are Restasis, Cequa, Vivi. Again, this was kind of the first of its kind in the dry eye sector. Historically, Restasis, it takes 3 to 6 months to work. So these are medications that you really need to use consistently and need to be really diligent with continual use. That's usually a tough thing to hear as a patient that you're going to use this medication for 3 to 6 months before you really see improvement. And I totally understand that. And that's kind of where Cequa and Vivi succeed, where Restasis kind of has a little bit of a shortfall there. Vivi works as quickly as 2 weeks, right? So it's a lot easier to know that you're going to find relief in a couple of weeks as opposed to a few months. And that's a newer formulation of cyclosporin that's been around for the last, I'd say, probably 2 years. These medications are twice a day dosing. They are typically covered by insurance. Your doctor will probably have to fill out a prior authorization in order to get it approved. But once you're on a medication that works, we like to continue it. So these are going to be your anti-inflammatory. non-steroid drops that you can be on indefinitely. And usually they're very well tolerated. There's not a whole lot of side effects. You may experience some burning, some stinging. And you'll see that it's true for a lot of these prescription medications, is that you're going to have some side effects. But the trade-off is you're gonna basically address the inflammatory cascade to help improve your overall signs and symptoms of dry eye. Next up, we have lifitegrast or Xiidra. This is one of those medications that you probably have seen on TV advertised. This comes from Bausch and Lomb, and it's very similar to cyclosporin in that it's an anti-inflammatory non-steroid that you can be on. It works as quickly as 2 weeks, and it's twice a day dosing. But it can take up to 8 weeks before you see the full benefits, is what I typically say with Xiidra. I always like to let my patients know ahead of time that two side effects to expect, burning and stinging, and sometimes you can get a little metallic flavor in the back of your throat. Otherwise, it's very well tolerated. And again, insurance should cover something like this. We may have to fill out a prior authorization to get it approved for you. Next up, we have Mibo. Mibo is also from Bausch& and Lomb, also probably advertised on your television. This is probably one of the best drops that I've seen on the market. I actually personally use Mibo, and I think it works well, and it has very few side effects in comparison to some of the other medications. Mibo is different in that it's the first and only drop that's approved for anti-evaporative or evaporative dry eye. So it's an anti-evaporative drop. It forms a nice oily layer on the surface of your eye to help retain your tears so that they don't evaporate as quickly. Mibo is 4 times a day dosing, so sometimes that can be a barrier for patients. But even if you use it twice a day is what I tell my patients, and that would be technically off-label, you're going to still notice some improvements. And this actually has relatively good insurance coverage, so a lot of our patients are not having difficulty in getting it, and a lot of our patients are noticing significant improvement. And so this is one that's easy to prescribe because patients feel better fast, it works, and it has very few side effects. Then we have a couple of new medications here, mainly Triptyr. Triptyr is from Alcon. It just came out in the last few months. And Triptyr essentially aims to basically stimulate your own natural tear production. So it's a drop that you would use, it's twice a day. And it's similar in that it tries to basically address some of the signs and symptoms of dry eye. Because it's a newer medication, it may be harder to get, but I typically, if patients are still symptomatic while they're on other therapies, I will consider adding Triptyr as an adjunct. So we're still kind of figuring out exactly where to position it within the dry eye algorithm. And then Tyrvaya has been around for a while. Tyrvaya is a nasal spray as opposed to a drop. And with Tyrvaya, so we'll use it for patients who have not responded to other therapies, patients who are not looking to really have a drop and would prefer to have a nasal spray. It's a twice a day spray. There are a couple side effects to be aware of. So sneezing is very common. I've had some patients report headaches as well. But overall, we'll use this in situations where the patient hasn't tolerated other drops, they haven't responded to other drops, or they're looking for a non-ophthalmic administration technique. And then that kind of leads us to topical steroids. So steroids are one of the most important treatments that we have in our arsenal, and I use them primarily in two situations. So I use them for flare-ups, and I use them to bridge patients while they're waiting for the other medications to take effect. So we talked about how cyclosporin and lifitegrast can take weeks or months to work. And so while patients are waiting for that effect to take place, I'll usually start a steroid as well, just to give you more immediate relief. Now, dry eye, I always tell patients it's not the steady state, right? So you're going to have times where your dryness is worse. You're going to have times where your dryness is a little bit better. So whenever you're in that worsening or the exacerbation or flare up, that's a good time to use a short course of a topical steroid like loteprednol or fluorometholone or the more common medications, just to bring you back down to your baseline. Very, very effective in providing quick and immediate relief for dry eye symptoms. And then that kind of leads us into our procedure-based options. So one of the most common things that we do for patients is punctal occlusion. Right in the inner corner of each eye, we have a little opening called a punctum where our tears naturally drain. And we can actually put a plug in there just to reduce how quickly your tears drain, and that helps keeping them lasting longer on the surface of the eye. There's a few ways that we can do occlusion, punctal occlusion. The way that I prefer is the collagen plugs. And I prefer them for a couple of reasons. So collagen plugs are dissolvable, so we don't have to remove them. They're not likely to come out on their own, and they typically last 3 to 6 months. And if you feel like they've helped, we can always replace them. And it's very simple. They don't hurt, you don't see them, you don't feel them. It takes 30 seconds to put them in the office. It's very quick. As opposed to silicone plugs are the earlier generation. They kind of have a mushroom cap appearance. So there's the mushroom cap kind of sticks out a little bit and it might actually cause irritation. So that's the reason I don't prefer them is because patients are more likely to feel them and they're more likely to pop out on their own. Regardless, collagen plugs, silicone plugs, and then the last category, which is Lacrofill, they're all covered by insurance as long as you have authorization. With Lacrofill specifically, that's the newest way to do a punctal occlusion. Essentially, what it is we take filler and we inject the entire canaliculus, the entire tear duct system. So it's nice because you get a nice full fill. It provides a little bit longer relief, and it can be replaced or repeated as needed. So that's a really good option. That's more of a newer punctal occlusion. Then, so once patients have sort of tried drops, they've tried steroids, they've tried punctal plugs, that's when I start thinking more about some of the advanced treatment options that may or may not be covered by insurance. And so, if you're still symptomatic at this point, it's really good to kind of consider one of these options to take you to that next level. Now, with the advanced therapies, let's start with IPL. So, IPL is essentially intense pulsed light, where we use this specialized light. It's a procedure that's done in the office. It takes a few minutes to do. You come in for 3 to 4 sessions, and essentially what we're doing is we're using the light to treat the eyelid margin of both eyelids. And the purpose is we want to reduce inflammation. And the way that it reduces inflammation to the eyelid margin is the light itself tries to obliterate some of those abnormal blood vessels that are in the margin. So it's really helpful for patients who have ocular rosacea, where you have a lot of redness and red blood vessels in the margin, because we want those blood vessels are carrying a lot of inflammatory mediators, a lot of inflammation to the eyelid margin. That inflammation leads to meibomian gland issues like blocked oil glands. They leads to blepharitis. And so if we're able to get rid of those mediators, the eye is going to look a lot quieter, a lot less inflamed. And so with IPL, you're effectively getting rid of some of those abnormal blood vessels over the course of 3 to 4 treatments to help improve your oil gland production, improve your dry eye, improve your meibomian gland dysfunction. So it's a really effective treatment. This is typically not covered by insurance, so it's not. I usually recommend it a little bit later on in the course of the algorithm, just so it's not a barrier for patients. Next up, thermal pulsation. This has been around for many, many years. And essentially, this is one of the heat and squeeze procedures where you come into the office, we hook you up to a machine. We have LipiFlow here at Harvard Eye. And the machine basically heats up the oil glands and then squeezes them to express the blocked oil. I kind of think about this, it's almost like when you go to your dentist. So you go to your dentist every 6 months or every year or so, and they do a nice deep clean for you, but then you have to maintain your toothbrushings at home. And similarly, you come in for LipiFlow, where we basically clean out your oil glands, a nice deep clean of the oil glands, but then you need to consistently continue your warm compresses at home to maintain that improvement. Typically, if you do benefit from LipiFlow, if you feel like it made an improvement in your dry eye, we recommend that you do it at least once a year to continue that improvement. There are some patients who will do it and don't necessarily feel a huge difference. So we'll repeat this for patients who notice an improvement because there are a lot of patients who report significant benefits after it. But if you've done it and you don't really necessarily feel that it made a big difference, then we kind of table it. Next up, we have serum tears or PRP tears. So this is really what we call our miracle drop, especially for patients who have a lot of inflammation on the surface and they have a lot of staining. I'll show you what staining looks like here in a moment. But serum tears is basically kind of our go-to if we have a very, very inflamed eye that's not responding to a lot of the other treatments that we talked about. And essentially what it is there's companies that will come to you, they'll do a blood draw, they'll take your own blood, they spin it, and they create drops that you would use out of it. The drops have a lot of healing and growth factors that we can't really otherwise access, and they essentially really allow the cornea to fully heal. This is typically not covered by insurance, and usually it averages out. We use a third-party company called Vital Tears. It averages out to about $100 a month or so, and you do it in 6-month increments. And patients that are on it will use it anywhere between 4 to 6 times a day. And usually, like I said, this is the miracle drop. Patients report significant, significant improvement with this. There are a couple of downsides. One we already talked about is that usually insurance doesn't cover it. And the second thing is it does have to be refrigerated because it's a biologic. So if you're going to be out of the home for an hour or two, they recommend that you pack a tumbler and with ice packs, and then basically leave the vial within that ice pack or tumbler, just so it maintains its integrity. So this very, very effective, especially if you have a history of like autoimmune conditions, you have diabetes, any of the Sjogren syndrome type situations. Really, serum tears are very, very effective at that. Next up, we have an in-office procedure called amniotic membrane. And so this is a procedure that's been around for many, many years. Historically, we kind of reserve this for really severe cases, not just very severe dry eye, but essentially severe corneal ulcers, corneal burns, things of that sort. But now we have different ways of administering it to the eye, and it's a lot easier for patients to tolerate. So we've been using it more and more for our dry eye patients. I prefer cryopreserved amniotic membrane because it maintains the integrity of the tissue. And so this is frozen tissue, it's never dried. It comes specifically from a company called BioTissue, and they have different ways of administering it. So that big ring that you're seeing there, that's called Procara. So it's a full amniotic membrane that we put on the surface of the eye, and we typically leave it there for a few days. With Procara, we leave it there for anywhere between 3 to 5 days. With the second variant, which is Cam 360, where it's just the tissue underneath the contact lens. You can see that there in the right photo. We leave that for 2 days. And these are different ways of basically administering amniotic membrane. We do one eye at a time because you can see it sort of forms a nice opaque layer, so you're not able to utilize the eye while it's on, but it has a lot of healing properties for the eye. So it's anti-inflammatory, it's anti-scarring, it's pro-regenerative. So it helps to regenerate the surface of the eye by stimulating your own stem cells. So it's very, very effective in chronic inflammatory dry eye. So if you're in that category where you've tried multiple therapies and you're still not seeing improvement, that's kind of when we'll think about amniotic membrane. And the nice thing is that this procedure is typically covered by your insurance. So we usually check your authorization ahead of time to make sure that your insurance will cover it, and then we go ahead and do it. And if we're going to do CAM 360, we usually have you come in on a Monday, Wednesday, Friday. Monday we do one eye, Wednesday we do the second eye, and Friday we remove the second eye. If we're going to do Procara, like I said, that one we typically leave for longer because usually the eye is a little bit more in a severe stage of dry eye. So this is actually a great example of the improvement that you can get with CAM 360. This is actually one of my own patients who had chronic severe dry eye, was not really given a lot of options, and finally came to see us. We put him on some of the topical medications, some of the topical anti-inflammatory medications, but he was still having a lot of irritation. And so we decided to do an amniotic membrane treatment for him. And you can see in that photo on the left, he has severe significant staining. So all that green staining on the cornea, those are areas of damaged corneal cells. And we put the amniotic membrane, in this case, on a Friday. We removed it on Monday. And you can see there's a lot less of that green staining pattern. Significant corneal healing occurred. And the nice thing is, every time we do this, he gets months of improvement. And so periodically we will repeat the treatment. Historically speaking, from the science out there and the literature that's been done, the improvements that you get for amniotic membrane typically last for about 3 months. Anecdotally speaking, from patients' experiences, I've seen 6 months, I've seen a year or so as well. And then finally, scleral lenses. So for patients who we've done all of these treatment modalities for, and they're still symptomatic, I will consider doing a scleral lens. This has to be fit with a specialized optometrist who's familiar with these specialty contact lenses. And the purpose of a scleral lens is it forms a nice moisture chamber for the eye to basically keep the moisture within and forms basically a little moisture chamber for the eye that helps to preserve it, helps to improve the dry eye signs and symptoms. Sometimes this is covered by your medical insurance, but really we wouldn't know until we sent the referral and had you kind of go through that process. But this I reserve for really, really refractory dry eye that has not responded to a lot of the other therapies. Now, how do we personalize your treatment plan? And we talked about so many options here, and it's hard to say which one is going to work for me. And a lot of it is going to be trial and error. And so when you come in, we do a full assessment of your ocular surface. So we're looking at your surface inflammation. We have a qualitative test that tells us, yes, there's inflammation or no, there's not. We also do fluorescein staining, which helps us to look for any signs of damaged corneal cells. Everybody fills out a speed score, which is a questionnaire that we do in the office that helps us stratify your dry eye, if it's mild, moderate, or severe. We look at your oil glands to see if there's any blocked oil glands. In a lot of cases, we will also assess the nerve health, the corneal nerve health, because that can play a role. And then we basically also look at your lifestyle, how well you would be able to manage some of these medications and really kind of find the best fit that works for you. So that leads us to our custom dry eye roadmap. Again, you come in, we do a full evaluation. We then start with the foundational medications like over-the-counter tears, warm compresses. From there, we can escalate to prescription drops like cyclosporin, lifitegrast, Mibo, depending on the type of dry eye that we're seeing. And then we'll consider in-office procedures like punctal occlusion. And then if you're still symptomatic at that point, we'll delve into some of the biologics like amniotic membrane or serum tears. And then lastly, for refractory, really severe cases, we'll consider scleral lenses or long-term maintenance therapy. Now, when should you see an eye care provider for dry eye? If you're having daily symptoms, if you're having chronic irritation, if you have redness, that's always there. Your vision fluctuates, you're having trouble with your daily activities, light sensitivity, over-the-counter drops are not working for you, warm compresses are not working for you, that's really a good time to seek an eye care provider. Millions and millions of patients suffer from dry eye, and a lot of them don't know that it's a good time to seek care. But if you're experiencing any of these on a daily basis, it's a good time to seek a consultation. And with that, I'll go ahead and open it up to Q&A. Leanna, if you can field some of the questions, if there are any, and we'll go from there.
Perfect. So right now there aren't any questions that we see on our end. If anyone has any questions, please put them into the chat box below so Dr. Ahmad can answer them. Or you can always email marketing@harvardeye.com if you do come up with any questions after the webinar. And a recording of this webinar will also be uploaded to our YouTube channel. We can wait a few minutes just to see if any questions come in through the chat.
Yeah, no problem.
All right, we just had one question come through. One of our attendees asked if there's any effect on Fuchs dystrophy.
As far as dry eye goes, no. So with dry eye, it's going to affect the surface layer of your cornea, whereas Fuchs dystrophy affects the innermost layer of your cornea. So if you have dry eye and Fuchs, you definitely want to optimize that as much as you can, but there is no inherent interplay between the two.
Perfect. Thank you, Dr. Ahmad. And one more question. After cataract surgery, how long do you have to use sustained eye drops or artificial tears in general?
No, that's a very, very good question. And most patients will experience some dry eye after any ocular surgery. So, particularly cataract surgery, I always tell my patients expect to have some dryness. And I typically like to use it. In a lot of cases, we'll use it for months, sometimes indefinitely if it's very severe dry eye. The reason is dry eye can impact the quality of your vision. It can impact your healing process afterwards. So I will use it at least a few months, 3 to 4 times a day, and then you can kind of taper based off of your response. But in general, in a lot of cases, you will have to use some tear on an as needed basis after cataract surgery to maintain the improvements.
Thank you, Dr. Ahmad. Another question is meibomian gland dysfunction caused by dry eye or vice versa?
So that's a good question. It's like a chicken versus the egg situation. Oftentimes, meibomian gland dysfunction leads to dry eye, but then if you develop inflammation as a result of meibomian gland dysfunction, then they just keep interplaying on one another. And so you really need to be able to break that cycle to help improve your dry eye symptoms.
Thank you. One more question. What do you recommend for a glaucoma patient experiencing conjunctival inflammation and dry eye?
Very good question. So, oftentimes with our glaucoma patients who are coming to see us for a dry eye, we'll recommend first switching to a preservative-free formulation. So, oftentimes your glaucoma medications will come in a preservative-free version. You may have to jump through a few hoops from your insurance to get it approved, but that's one option that really helps. Once you remove that preservative, it really helps the ocular surface regenerate. The second thing that you can consider if you're a good candidate for, and you can ask your glaucoma specialist, is if they can do SLT, which is a laser procedure that is done in the office to help lower the pressure. And that's a way to actually just get off of drops completely. So ask your doctor if SLT is a good option for you.
Thank you, Dr. Ahmad. No more questions as of right now. Let's see if any more come through. A patient just thanked you for a very comprehensible and expanded presentation.
Of course, thank you.
Perfect. And if anyone else does have any more questions that come to mind after the webinar, please email marketing@harvardeye.com. Thank you so much, everyone, for joining tonight. And again, a recording of the webinar for all of you to rewatch will be up on our YouTube channel. Thank you so much, Dr. Ahmad, for this presentation.
Thank you guys. Have a good night.